Oh, you'll have got in now. So,
hi everyone. Thank you very much for joining us. We are here for Seminar 6 in the Learning Together for Better Lives series from the Health Determinants Research Collaboration. I'm sorry that we're starting a little bit late here. We were having some slide issues and there's some work ongoing in the background while I'm speaking here. So we'll see what happens. I'm Fanula. I'm your host. I'm with the Health Determinants Research Collaboration for Aberdeen, which is an organisation supporting ACC in advancing and maturing its research activity and its research identity. Of course, research is already being done all the time in Aberdeen and other local authorities. What we are doing here is building on that towards even more data and evidence-based decision-making for ACC and its partners. This session is being recorded. It will be posted on the Community Planning Aberdeen YouTube channel. I will share some links to that and other things when we get started. You have joined muted, so while Paul speaks, you won't have any danger of talking over him, but when we move to the Q&A component of the session, I will change the settings so you will have the option of unmuting yourself and asking your question out loud. Equally, you can drop your written question into the chat at any time, and I will coordinate all of that so Paul can concentrate on presenting. I will also include a feedback link, so if you have things you want to share there about the session and how you've received it, I would love to hear your feedback. And that's all of the housekeeping. Our topic today is economic evaluation, and our speaker is Professor Paul McNamee from the University of Aberdeen. We are running Paul's slides for him, so you will have the next slide, please, statement. But otherwise, thank you very much for coming, everyone. And Paul, over to you.
Yeah, hi there, and thanks for the invitation. So yeah, great to be here to tell you something about economic evaluation. I've been a researcher now for, about 30 years now, I would say. And probably most of that time, at one time or another, I have been engaged in at least one project which does involve an economic evaluation. However, in terms of the evaluation component, it's predominantly been healthcare evaluation that has been my focus. But more recently, over the last 5 to 10 years, there's been some population health work I've also been involved in. So the objective then of this session is to broadly understand a little bit more about the economic evaluation of policies or programs that aim to improve health and well-being. So really, you may have done or be considering an evaluation. So the question kind of becomes, do you think you require an economic evaluation, either alongside that or perhaps afterwards? You've got the evaluation results and you're thinking about implementation, and you really need to consider perhaps the resource impact of implementing. And so economic evaluation can inform that decision. Probably we would always advise you to think of economics and the health economics issues right up front. So if you are embarking on evaluation, you probably do want to be thinking about economic evaluation right from the outset, and I'll try and convince you why that's the case. So first of all, in terms of the breakdown, what I'm going to talk about, the first step is the rationale for using these techniques of economic evaluation. I'll then say a little bit about one of the criteria that underlies this method, and I'll focus on one of the main criteria, which is efficiency. So I'm going to do a little bit of a dive into some definitions. Not going to spend too much time on that, though. I want to then move on to the different types of economic evaluations that there are out there. They all have some quite common features, but there are also important differences between them. And I'll be focusing on probably what we would like to think of as the most useful and certainly the most widely used one, which considers health-related quality of life and well-being. So we talk about something called the quality adjusted life year, or the QALY for short. So I'll say a bit about that, and then finally I'll towards the end I'll get into a little bit more about how we go about estimating cost effectiveness when undertaking an economic evaluation. Basically, what types of information should we be looking to collect and how we might go about collecting that information. So I think I can have the next slide. You move on. Yeah, so the starting point then is, and why we use or why we might be interested in economic evaluation is scarcity and choice. So this is economics 101 now. We are concerned in economics with how limited resources are used to allocate goods and services, and we try and improve, if we can, or inform the allocation question, as we call it. Why do we need to think about allocation here? And the reason is the scarcity. We've got more ways of using those resources than there are resources available to us. We can think of that in terms of our everyday life, and think of time as a resource, really important resource. We've got lots of different ways we could be spending our time, using our time. We want to make sure we're using, getting the most out of that time. And certainly within the healthcare sector, we know it's ever been the case that healthcare resources are very, very limited, more stretched. They're always stretched, and again, we are in a situation where resources have been fairly flat and not really increasing in real terms. So we really have to be sure that our choices we're making over what we're doing in terms of what services we're providing are giving us good value for money. And this is where health economics and particularly economic evaluation can come in. And the reason it needs to come in is of this concept we call opportunity cost. As soon as we devote our resources in one way, we lose the chance to use those resources in other ways. We give up the chance of using them in those alternative ways. And that's the opportunity cost here. That's the central concept. Underpins economics, and it's no different in terms of economic evaluation, in terms of how we go about doing an evaluation. So next slide, please. So what is opportunity cost then? I can't emphasize it enough. So let me give you a formal kind of statement here. It's the value of the benefits forgone when deploying resources in one way rather than in another way. And in that other way, we're thinking about the next best use. What we could have had, but didn't choose to have because we've deployed them in one way relative to another way. So next slide, I'll maybe unpack that a bit more. Next slide. Yeah, so given an example here, so public health, the public health team, health promotion, health improvement, prevention of ill health is the maximand, if you like, what we're trying to do in terms of the objectives of the public health team. A couple of different examples there. We're maybe using some of the resources from the public health team to help people manage their weight. So we may fund a weight management program. So we may use some of the staff time from the public health team and other parts of the budget from public health to run a weight management program. That is competing with, of course, other ways that we could have helped people to manage health. But not only that, it's competing with all sorts of other things we could have been doing to help improve the population health. Give you one example there, alcohol reduction programs. And there are many, many others. So the opportunity cost is potentially quite large, and the alternative uses of those resources are really quite a long shopping list. So we really want to make sure that if we're devoting resources to that program, it's giving us a good return from that investment. And that's essentially what economic evaluation tries to set out in a framework, a formal kind of decision-making framework. So I think the next slide here would be good. Yeah, this is just the statement here that I've set this comparison up the next best use here of those resources could have been the alcohol reduction programme. So we are losing some health and well-being gains. The more we put into weight management, the less we're getting out of the alcohol reduction programme and other potential uses, potential programmes. They are now lost from us. It's not to say we can't change our decision in the future, but here and now, as soon as we commit, we're committed to that for a particular period of time. So next slide then. I'll have, so just to emphasize again, the way to think about an economic evaluation is a framework for decision making. It doesn't make the decision. It helps you set out what's important in the decision. It leads you to think about the amount of resource commitment for that investment decision. It crystallizes thinking around what are we gaining from that investment, over what time period are we gaining from that, and what are we losing that we could have done with those resources? How could we have used those resources differently, and what that would have provided? Try and set that out. And all the time, if we're going down that route, we're hopefully, when we've mapped that out and set that out and attempt to measure that, we should arrive at a place where we've maximised, or at least attempted to maximise and improve population health here, health and well-being. And by doing so, we've minimised the opportunity costs at the same time. So next slide. Okay, there are many textbooks on economic evaluation. One of the first that arrived, and probably the kind of godfather of economic evaluation, if you like, in terms of getting the field on the same page, and certainly for growing the discipline of health economics, is someone called Mike Drummond, and that definition comes from a chapter in his book. So, and we're using it still to this day. So it's the comparative analysis, alternative courses of action, in terms of both their costs and consequences, right? So it's really important that there's a comparison. You are comparing one decision with at least one other decision. So here we often talk of health programs. The setup I've just described there, a weight management program could be compared with other ways to help people manage their weight. Or you may be thinking about the bigger budget in terms of public health and what we're doing in terms of our public health team, and looking across the board at current spending and considering what that is giving you in terms of health gain, health and well-being gain, and also how much it costs to deliver that gain. So we're setting out how many resources are being used, the value of those resources in terms of the monetary value, and what it gives us in terms of health benefit. So it goes beyond evaluation, which would look at effectiveness and whether something works. And by bringing in resources alongside effectiveness or benefits, we are then considering efficiency at that point in time. Excuse me, next slide, please. So there's more than one definition of efficiency then, and quite often in health economics we talk about technical efficiency and allocative efficiency, and different forms of evaluation answer different questions, and so different types of economic evaluation give you an answer sometimes on cost effectiveness, and sometimes they give you an answer around allocative efficiency. But broadly, all economic evaluations are seeking to try and improve one of these types of efficiency. So another way to think about then economic evaluation is we think of it as setting out a framework in terms of we're thinking about inputs on one side and outputs on the other. So our inputs are our resources. So these are the amounts of healthcare. So that we could measure that in terms of staff time involved in healthcare delivery. We can also think of the inputs from the patient or the population in terms of their health behaviours, so their physical activity, their diet, and we put together inputs to produce output. And output here is health and well-being. So when we talk about technical efficiency, we're saying we're producing as much output as we can from that current mix of inputs. So we're doing as much as we can as possible, or we're using as least amount as possible of inputs for the output we're seeing and generating. So that's all well and good. However, what technical efficiency and also cost effectiveness, which is about looking at the value of resources, that doesn't tell us how much to produce or whether the output should be produced at all. So the allocative efficiency part of efficiency is dealing with that head on, and we're incorporating information on preferences and value of consumers for that output. So essentially we are getting some information on what people, the public, wish to see in terms of health and well-being. So by providing some information or using some information on preferences and values, the size, how important particular dimensions of health are, and which ones are most highly valued, then we can start to think about that question around, for instance, the weight management question versus the alcohol reduction program. So it allows us to some extent do that apples versus oranges comparison when we've got information on what dimensions of health and well-being people really value the most. Okay, so let me move to the next slide, please. Let me say something before I go on to the different types of evaluation. Something about resources and what we mean and how we go about measuring and valuing resources. So this is us talking about the inputs now, the cost side, and what we need to start thinking about if we're about to embark on an evaluation of some kind. So we've already said that it is the use of resources, and these resources all have opportunity costs. And then because of this concept of opportunity cost, we want to carefully identify, measure, and value resource use. And it's only by doing that we get a handle on how much input does this program really use. And that's the cost side, because we're interested, as I say, comparing the cost side with the benefit side. But let's just focus on the cost side for now. So what do we include then? Well, items to be included are really those resources likely to have an important opportunity cost as a result of being used in the program. Okay, so the starting point is, right, what resources are required to deliver this program? So next slide, please. So this is a listing that we probably would always start from if we were embarking about to do an economic evaluation and at the planning stage. The number one resource in pretty much most healthcare programs, and this goes for public health, population health, as well as healthcare, health interventions, is the amount of staff time that's needed. Staff time has got a big opportunity cost. And so the types of things we're thinking about are any, and if it's a new intervention or a new program, a new staff it's either existing staff trained to deliver something a new way, or it is new staff. There will be a training element to that. So we have to think about how much training time we're using. We also have to think about how much contact time is required to deliver that health improvement. So how much face-to-face contact people are having with the service. And we measure that. We measure that and we record time. Who's delivering that and for how long and how many? What is the reach in terms of how many people are receiving that service? So that's the kind of intervention cost part, if you like. That's only one part of it, though, because one of the things that may well happen, if the intervention is effective, of course, it's going to impact health and well-being. It may have some downstream savings in the system. So if an intervention makes people healthier, you may see less visits to primary care. There may be less medicines use. There may be less hospital visits. So we record prospectively, if we have the resources, research resources to do it, track that resource use over time, the knock-on downstream effects and also that accompany that intervention. Because some of the intervention costs could be recouped by some cost savings relative to the comparator. The other things we need to bear in mind and consider is there any impact on other parts of the public sector, social care, other parts of the public sector. If they're either required in the delivery of the intervention or there's some knock-on effects in terms of potential savings, again, we want to identify and measure those. Now, depending on the perspective of the evaluation, we may also wish to include the time of patients and carers, and we may also wish to identify and measure any production losses, and that's not just from paid employment, but it's also absence from volunteering, people and volunteers, unpaid care, and so on. So next slide, please. Which brings me to this perspective. So that we need to be absolutely clear and upfront about the perspective right from the off, because that will inform what costs we will include in our evaluation. So we have to make explicit that perspective from which we're conducting this evaluation. So the perspective has, as I say, major implications on the costs in the evaluation, and I list some of the main ones there, running from the NHS perspective down to the societal perspective, which basically captures everything above that final bullet point. Let me say a little bit about this, because really this is really quite important to get right. Whether you get it right or not does depend on the policy question, and it does depend on the intervention or program here. So we can't always say one perspective is correct and one's incorrect, but we do need to adjust the perspective depending on the policy question, if you like, or the policy decision, and the type of program or healthcare intervention it is. What's its main purpose and overall measure of success? What are the mechanisms of action? So we need to really think through at that planning stage what for instance, the pathway is to achieve those outcomes. It's very common to have a health, and the second bullet point there, the health and personal social service perspective. That's the default perspective that's adopted by the National Institute for Health and Care Excellence. That's the body responsible for oversight of medicines and healthcare technologies in England. So they have a guide for conducting evaluations, and that is their recommended perspective to adopt. So that is really quite interesting, because it does suggest they're not interested too much in patient and carer costs. Neither are they interested in other parts of the public sector and neither are they interested in a societal perspective, which might have included productivity effects. So it's actually quite a narrow perspective. But when it comes to public health and evaluations done under the public health programme, there's a bit more flex in the system, and more often than not, we do adopt a wider perspective and include all other elements of the public sector. So social care, other parts of local government, and consider patient and carer time effects as well, rather than just adopt that narrow perspective. So next slide, please. And yeah, one of the reasons for adopting that wider perspective then are the wider benefits that some, many population health, public health programs achieve. They go beyond health-related quality of life improvement quite often. Quite often that's further in the future. If you think of some elements of health promotion programs, you don't often see or it's difficult to measure health-related quality of life improvement. It's often difficult to measure survival. And I'll say a little bit more about that in a moment or two. And we can only sometimes just tap into the intermediate outcomes. But we wouldn't want to ignore those wider benefits, because we are then undercounting the benefits achieved or could be achieved by that programme. So, as I mentioned, productivity, both work in terms of work, both paid and unpaid, and people's general ability to go about their everyday life. So, improving empowerment, improving people's capabilities, information provision is improved. We may have a programme that helps people retrain back into the labour force, and improve their own life and life satisfaction through changes in their education, to changes in their labour supply, differences in volunteer activities, and so on. So there's many facets of so many population health, public health programs that if we were adopting a narrow perspective focused on qualities, we may miss some of the benefits. So next slide, please. Okay, this was just a short slide, and this is maybe more for information that where you get, you often might wonder, where do we find the numbers from? If we're undertaking a economic evaluation and we're counting visits to hospital, inpatient stays, GP visits, where do we get these numbers? How do we know how much it costs for that GP visit? Well, there are published sources that we go to. Some of these volumes are Encyclopedia Britannica, so they are difficult to navigate. So there's the Scottish Health Service costs, which used to, I think, sometimes still call it the costs book, and also for health and social care, particularly social care, and also visits to the primary care team. That second bullet point there in the unit cost manual is the place we would be going to try and arrive at the appropriate unit cost for that. So that's all I'll say about that. So next slide, please. So let me then move on to these different forms of analysis. We can when we say we're doing an economic evaluation, I've listed 4 there. This was maybe a slightly older slide I have. We don't often label things in terms of now 4 types. There are some more variations on this theme, but certainly if you read some of the main texts here in economic evaluation, they still talk about these 4 types. So I'll stick to the same. here and just quickly run through these, but I want to focus on cost utility analysis and the quality adjusted life year if I can. So next slide, please. So the simplest economic evaluation you can do, right, is something called cost minimization analysis. Why is it simple? Well, it's simple because you focus entirely on the costs of the intervention and possibly some of the knock-on effects as well in terms of the knock-on costs, right? But the only reason you should be embarking on that type of analysis, though, is you've already got high quality published evidence that effectiveness and other relevant outcomes, such as side effects from an intervention, so the unintended consequences, if you like, are equivalent, right? So if you need at least one high quality systematic review, I would say, more if there are available, but certainly one very high quality randomized controlled trial. And that's been done, and it shows, look, there isn't any difference. There's no significant difference between program A and program B. And you're interested, decision maker, which one to go for, which one to provide to patients. So one element then you may probably wish to consider is the costs of that intervention, cost to deliver and run that intervention or program. And you could embark then on on a costing study, knowing the prior knowledge is there, these things are equivalent in terms of effects. That's a relatively straightforward study to run. You don't need to collect any more information on effectiveness. And the decision rule is quite easy. You just choose the cheapest. You choose the cheapest program in the knowledge that your outcomes are going to be the same. So you're being technically efficient here, if you like, by choosing the cheapest. You know, the output's the same, but we're interested in minimizing the input because of this opportunity cost, where it's in the back of our head. If only it was so easy, and we have lots of examples of that. Most healthcare intervention public health programs, A, either haven't been evaluated fully, or B, they have, and we actually do find a difference. The other thing to bear in mind is we'd also like to have some information on people's preferences as well. So without that, really, there's lots of missing information. The reason I mention it is it is still used in medicines evaluation, and Scottish Medicines Consortium. They do use it fairly routinely because lots of drugs are what we call Me Too drugs, and they've got the RCT evidence. This new drug ain't any different in terms of its effectiveness. Little to choose in terms of side effects. So lots of economic submissions, as we call them, that go to SMC, Scottish Medicines Consortium. Yes, RCT, randomized controlled trial. Rely on what's called a cost minimization analysis. Next slide. So that's cost minimization. Because that's rare, we do have to think about the output and the dimension of effectiveness. And some examples here. This is earlier in the discipline, maybe, of economic evaluation, before the quality adjusted life year was invented in the 1980s. Let's say you saw lots of studies in economic evaluations measuring output in terms of life years gained, cases detected. It's a diagnostic comparison, or other clinical measures of improvement. So does this new drug lower people's blood pressure, and what's the drug that lowers the blood pressure the most, if we're aiming to lower blood pressure amongst people who need it lowered? The challenge with that is you cannot do broader comparisons between different disease areas and population health. The other limitation is there are often multi-dimensional multi-dimensional elements of effectiveness. And you're interested in often going beyond the clinical measurement of whether it achieves an improvement on a clinical indicator, and what can the patient do as a result of that improvement on a clinical indicator. Does it help them to live their life, how they would like to live it? So let's move on then to the next slide, because to get around that limitation, this is why we've arrived at cost utility analysis. So cost utility analysis, here we're working in multi-dimensional units. We're combining survival with quality of life and put the two together, and we arrive at the quality adjusted life year. We can compare many different types of healthcare program, many different programs in public health and population health. We can undertake those broader comparisons. So next slide, please. One of the things that you will see I'm about to show you, and also when you look at the headline results, say from an economic evaluation, is trying to get a sense of the value for money. How much bang for the buck do we get? And we summarize that using using what we call the incremental cost effectiveness ratio, right? Now, all it is a summary calculation that we do. What is the extra cost and it tells us what's the extra cost to achieve that additional unit of that outcome. So what is the bang for the buck effectively? So we estimate the cost of the new program, the cost of the current, look at the cost difference. Same for effectiveness. The effects of the new relative to the current, take the difference, divide that the cost difference by the effect difference, and that is giving us this ratio, and we use this ratio to inform the decision. So it's whether this ratio, how large the number is here, will inform kind of a recommendation, if you like, whether something is or isn't cost effective, or how cost effective something is. So I'm just going to show that now in the next few slides. If you can move on. Right, I think I've already said that. If you move on again. Yeah, okay. So just to emphasize the point again, quality adjusted life year, it's all about measuring how long you live and how good that life is when you're living it, on a scale from 0 to 1. 0 being you're not alive anymore. 1, perfect health. And you put if we know we track people over time, we're interested in knowing how good that time is in terms of its health-related quality of life. So here, if you live for 10 years and we track someone for 10 years, they're in 85% of perfect health. Their number of qualities they have would be 8.5. So next slide, please. This is a more detailed calculation. I probably don't need to go into the nitty-gritty here, but this is the type of thing we might see if you take the average patient from Program A and the average patient from Program B. Those might be the profiles you might be seeing. Not unusual to see a profile like that over the course of a year, where there's some improvement in, say, usual care, the red line, the blue line showing greater improvement, and that's for the sake of this slide is qualities under profile A. And we take what we call the area under those two lines, and it's the difference between the two is giving us the quality gain between those two lines. So the quality gain is that 0.77 less the 0.69. So that's a gain of approximately 0.08. Now, we're interested in knowing then, is that good? Is that how does that stack up? We are interested in the business of looking at how does that match up against costs. So that's one side of the picture. So next slide, please. Before I get to that, though, this is where I had my PowerPoint slides, which had some animation going on. You could see these slides, these lines being constructed before your very eyes without me drawing them. But anyway, these are some examples of the types of health gain we can receive from intervention. So I'll skip through some of these. So this is one, for instance, where we've got prognosis, expectation of life and quality of life without the intervention. We've got a situation where we have an intervention halfway through that time horizon. It massively improves quality of life, and that's the size of the health gain there. So next slide, please. And I think it'll be the next few slides where I run through some examples of increased survival. That's an increased survival. Next slide. That's quality of life improvement only. Next slide. That's survival and quality of life we're seeing there. You're shifting time to the right-hand side, and there's some quality of life improvement. To next slide. Yep. And here we're getting improved survival in the dashed curve, but we're also getting some reduction in quality of life. So some cancer treatments, for instance, make you worse off to begin with, but in the expectation you might live a little bit longer. And we want to net off the gain against the loss for that intervention. And the quality allows us to do that. So next slide, please. Okay, so how do we arrive at the quality weight? Okay, the quality of life weight. We can use off-the-shelf what we call generic utility-based quality of life tools here, right? So these are health-related quality of life tools. Now, they're probably quite difficult to see, but just focus on the one on the right-hand side. This is something called the EQ5D. So 5 dimensions of health. We measure health in terms of its mobility, self-care, usual activities, pain and discomfort, and anxiety and depression. We would ask our respondents in our evaluation to record their health on the EQ5D at a baseline, then maybe 2 or 3 other points in the study, and we can then track how health-related quality of life is changing over time. And we can do that for a patient population in our study, and we can arrive at the graphs I've just shown you there. And if we're doing that for our new program versus our current program, we can track quality of life. Hey presto, we can then produce our quality calculation. We don't have to go to the trouble of working out how to construct a value between 0 and 1. That's already been done by the developers through some preference surveys they did some time ago. So that comes with that instrument. We've got off-the-shelf quality of life tools and off-the-shelf values. So next slide, please. I'll try and wrap up in the next 5 minutes. So time for Q&A. How we present results then, going back to cost effectiveness, and we've talked about qualities and the size of the quality of life improvement, or the quality difference being important. How we summarize our results in our evaluation, we talk about something called, we've got a 4-quadrant diagram essentially, and we give it the label the cost effectiveness plane. What it is a map, if you like, of how the new policy compares against the current policy. And we're interested in knowing where our data points are on this map. So what we often see are, and if you think of this as effectiveness difference That's what E stands for, the E2 minus E1. So that's the effectiveness or the outcome difference. So think of the quality gain here. We'd like to have a quality gain. So we'd like to be on the right-hand side. That's showing effectiveness is improved. Also, we've got the cost difference between the new treatment and the old treatment. When we're on the top right-hand side of this diagram, this is the common part of this map we are in, where the new policy or program is more effective, but it's also more costly. Things which are in the top left are situations where programs more costly, this new policy is more costly and less effective, and there'd be never a situation we'd want to adopt those programs. And equally, we could be on the bottom right, where the service is more effective and less costly. Now, those are winners all day long. Quite difficult to find, but where we can find our new program being more effective and cheaper, then we'd be in a rush to adopt those types of healthcare programs if we can. So that's how we kind of summarize the information. I'll give you a couple of empirical examples if we can. Next slide. Yeah, that's maybe quite difficult to read, but this is the top right of this map I've just described to you. And this is a set of data points using our estimates of cost and effect from this one study. And this is how we would make a judgment on whether that incremental cost effectiveness ratio is high or low. So what happens is we're interested in knowing quite often a decision maker, and this is applied to health more than public health, is the cost per quality gain less than £30,000 or not? If it is less than £30,000, we're on the right-hand side of that 45-degree line you see in that diagram. If it's to the left, then it's saying the incremental cost is quite high, the gain is quite low, our ratio is going to be over £30,000, which is usually said to be too expensive. So we would tend to say, sorry, we just can't afford that intervention. And that's an example here from a study, an exercise referral done by a set of other authors. So next slide, please. This is one of my own. This is a study we did in a weight management program delivered by the Breast Cancer Now charity, where staff were trained and deliver motivational interviewing to help women lose weight who came to breast cancer screening. It was quite an expensive program to deliver. It did have some benefit, and you can see here what the incremental quality gain is showing is when 70% of the occasions, in terms of our distribution of costs and effects, it did have some improvement. 30% of the time it didn't. Put all those figures together, there was only 20% of the occasions, 20 to 30% of the occasions where our cost per quality was below 30,000. So it was slightly better than the exercise referral example I gave you earlier, but still probably on balance, this intervention needed to have more effect to be judged to be cost effective, just taking the results from the study. Next slide, please. What I was going to end on is I've talked so far about economic evaluation, but not really told you how we might go about it in practice. I've mentioned the randomized controlled trial. That is quite a common way of of doing our evaluation at the same time as that randomized controlled trials going on. It doesn't need to be, of course, a randomized controlled trial. That tends to be the best evidence in medicines and healthcare. It's a bit more different in public health and population health. So more often than not, we're using some evidence on effectiveness and costs from trial data where we have it, but more often than not, we're using other forms of evidence and other information sources and putting that all together in a decision analysis model. So that's how we can also do our evaluation, taking elements of information from very different sources and putting it all together to form an evaluation. Next slide, please. Next slide. These are just the advantages of doing it with RCTs, but there are limitations of RCTs. Patient selection being one of them, quite a highly selected group. There's a kind of form of selection bias in terms of who goes into an RCT, and they can't give us all the information we need quite often. So next slide. So quite often now we are going down the route of doing a trial or some other form of evaluation. We want to make it as pragmatic as possible. Few exclusions, make sure we're comparing with the current standard of care, really important. Following people up under routine conditions. So it's routine follow-up to get, there's nothing added on for the purposes of the trial. And there's a movement now to kind of get that more into embedded within RCTs and randomized controlled trials under the realist banner. So realist economic evaluation is now a label that's used. So next slide, please. This is basically saying we can't avoid doing modeling because the trial doesn't give us all the information we need. And it's certainly in the field of population health and public health. There are many, many limitations to that trial evidence, and I listed some there around. We always have to, these trials stop. You know, they only last a finite period of time. We're interested in knowing as decision makers what happens to people after the trial stopped, and quite often we don't have that information. We're also interested in making sure that the trial participants are generalizable to the population. Often they're not. So we often are on the search for more realistic, better sources of evidence. Next slide, please. Keep going. Next slide, please. And I think I won't say anything about cost-benefit analysis. That is another form of evaluation. Next slide. Just stop at this one before my summary slide. So the difference here, just a few words about cost-benefit analysis. It does have some something to offer in terms of population health and public health interventions and programs. We are often interested in very, very disparate sorts of improvement and benefit. There's many, many examples in the field of diagnostics and service redesign where it's not necessarily health-related quality of life might improve, but other things that might matter to people improve that are not captured by the quality or the quality adjusted life year. So we can undertake cost benefit. If we wish, we can also just undertake that preference elicitation study and just try and capture people's preferences for that service redesign, match that up against the costs involved with that redesign and put the two together. It may not be called a cost benefit analysis, it's give it another label, but it is going beyond the quality and also including some resource use. Then it becomes an economic evaluation. So summary, let me stop at this point. Final slide. I'm sorry I've rushed through that towards the end. We did start a little bit late. Basically, economic evaluation is a tool. It's a technique that can be used to inform resource allocation over allocation decisions, and resources are scarce in the system. Which technique to use? First of all, think about do you require an economic evaluation to improve decision making? Is it relevant in the decision that you're at in terms of service design, redesign, or program improvement? Choose the technique the choice of technique, you choose a technique depending on the policy question and the intended outcomes. What is going to happen as a result of this? What's the measure of success? And the final thing we should not forget about is thinking through, and this is where the realist approach comes in, what are the wider drivers of health and well-being we're seeing in that evaluation? What are the determinants of that health and well-being change? It's occurring. So we always, where we can, are looking to measure the effects in different population groups. Are certain people benefiting more than others? Why that might be the case? Is there any way we can make interventions more beneficial in particular population areas, and just getting under the bonnet of why things work and why they don't work as intended? Next slide, I think, is coming up to the final slide. I think it's that point. Some extra sources, and that final slide. Thank you for listening so far, and I'm very happy to take questions and comments now, or even email, chat, or afterwards. Thank you.
That's brilliant. Thank you very much, Paul. I appreciate it. What I'm going to do now is hopefully allow people to ask questions, which you can do either by raising your hand or dropping your question into the chat function. I see a little notification. Is there a question already? Oh, I see the notification, but not the thing. But also I see Martin Murchie is on camera. So Martin, is there a question you'd like to ask?
Yeah, thanks, Fanula. Thanks, Paul. That was really interesting. Kind of took us, as you say, from Economics 101 through to some really difficult issues. I'm going to rush this question out because I've got a minute before I need to shoot off to another meeting. So apologies for that. I was just thinking, as you're talking me through it, sort of relevance to the local authority in particular, and I sort of had a macro level thought, and then trying to think that through the micro level from my experience. So just to kind of reassure people how important I think these things are, I'm now boring people by pointing them to the report from the Scottish Fiscal Commission last year around fiscal sustainability for Scotland. And it was absolutely clear and unequivocal that the biggest factor in the risk to the sustainability of Scotland in its public sectors is the health of people in Scotland, and we are less healthy than other places in the rest of the UK. And if we were able to just have parity in terms of our health in Scotland with the rest of the UK, there would be significant closing in the gap of our from being on the precipice fiscally as a nation. So that's the macro level, and kind of so you can see how important these decisions are that we're trying to make around the health economics and the choices we have to make. So all that taken as read, then I'm thinking that through to the micro level, and there's in the wider determinants of health and the things that local authorities can have an impact on. And there's a whole gamut of things from education and housing and open spaces and transport and everything else. But the thing, and I'm just kind of bring it down to a level that hopefully everybody can understand and then see the difficulties in it, is something that comes up every year, predictably, and has done for the last 20 years that I've been involved, which is this thing about winter maintenance and slips and falls for folk ending up in hospital. And the argument goes, if the local authority created more pavements and streets, there would be less people falling over, and that would save money. I've never quite understood that, because it seems that if you look at it from an individual organization perspective, then the money is seems to be non-cashable savings or wooden dollars in some sense, and therefore where is the incentive for the local authority to put pressure on its other budgets and other areas of service. If it isn't actually saving any money, it's taking a bit of pressure off another part of the system. So my conclusion to that is, sorry, Paul, this is a monologue rather than a question. We really need to, and this is where the collaborative nature of the HDRC is really important, I think. If you begin to look at things more as a system and less as individual organizations, you can factor some of this stuff into economic evaluation and try to take that picture of where actually are the costs and the savings and the benefits coming from these things. So I don't know if that's a question, but that was what I was thinking, Paul.
Yeah, I mean, it doesn't help when some of the perspectives that people undertake their evaluations from are health or even just health and social care, and they're very, very limited in the time frame. But yeah, I take the point that the budget for the salt is coming out of the local authority pot. The healthcare use is coming out from a different budget line, a different organisation, and the two aren't integrated together. Although even if they were, I guess you have to think through that saving in that fall has, if that fall never happened or wasn't to happen to a large enough proportion of people, but even one, just take one element, the ramification for other family members as well as the individual themselves, and the time lost. So and you're right, it's not usually cash. It isn't cashable in, but it does have ramifications in terms of time use for lots of other people as well as the individual who falls. And sometimes that is maybe not apparent or explicit enough in evaluations. I don't know where that gets you in terms of incentives, though. I think you do have to kind of think of the incentive structures for joint budgets as maybe the answer. Maybe that was one of the purposes, as I understood it, was for integration, health and social care integration. But maybe there's not enough integration. Is maybe the answer. Is not everything is integrated. So yeah, but yeah, more broader evaluations might help. More integrated budgets might help.
Thanks, Paul. I'll shoot off now. I'll catch you later. So yeah.
Thank you, Paul, and thank you, Martin. I see there's a couple of other questions in. B, you're challenging me with the length of some of these questions, but I think I can shorten a little bit. The first one is short. Paul, the willingness to pay threshold of a £30,000, is that a fixed figure, or does that vary with budget or other things?
It's right. There is flexibility around it. That 30,000 is kind of the upper limit. An upper limit that used to be there in the healthcare decisions, stress healthcare decisions. Scottish Medicines Consortium had this 20 to 30 figure. They often like to see things under £20,000 per QALY. When this, you might wonder, well, where did this figure come from? It's not when it was first used by NICE in the late 90s and early 2000s. It really didn't have any empirical basis whatsoever. And so where it came from was, I think it was a position paper from a group of health economists in Canada. So they take the dollar figure and put it into sterling and came up with that figure. And it's never really been inflation adjusted. So it's a way for NICE to it was a way for NICE to make not quick decisions, but decisions that were transparent and had they could stand up in court effectively and couldn't be challenged by the pharmaceutical industry. And so this kind of creation of the level playing field appeared. And over time, that's been embedded and locked into the system in health. But in social care and population health, public health, there's definitely more flexibility. Quite often economic evaluations aren't done using cost per quality. Sometimes they are, and you also do something alongside the cost per quality. So the cost per quality isn't the be all and end all when it comes to population health, local authority decision making. It's quite often we use, even in social care, there's other measures of benefit now that are not health related quality of life. They're capability related. And now there's something called the well-being years. So the well-being adjusted life year, which captures kind of those dimensions of kind of well-being, what it is to have a good life, income, a decent income, good housing, social relationships. There's no social isolation, all those other things besides your own individual physical and mental health. So yeah, but it is still around. In fact, final word on this, only today there's some development around changing that figure from 30,000 to 35,000 pounds per quality. So things the healthcare budget might be even more constrained because more medicines and treatments are being approved, which is a good thing for patients, but there's this knock-on opportunity cost that you maybe can't treat everyone now, and you have to think of selection of patients because it could start to even put more and more pressure with expansion of coverage of different medicines than there otherwise would have been. So it's a really difficult difficult problem, and the solution has been the cost per quality, but it does store up other problems in the system because it's not immediately tied to budget impact. Because the cost per quality is an individual based metric for an average patient, the average patient population. It says nothing about how many patients does that cover. What's the population coverage? So you could have a very low cost per quality, which is a good thing, and cover more people, lots and lots and lots of people, which is great. But equally, that high cost per quality could be there, and that medicine could still be approved. In fact, that does happen for rare diseases and the rare cancers. And the reason it does is through a kind of fairness argument that it's not that individual's fault. There's no incentives for the pharma company to invest because it is so rare. So we have to create different incentives for the pharmaceutical industry to invest in R&D for these drugs. Otherwise, these people are going to be left behind. So that's why. So there's some flex in the system for rare diseases as well, where the cost per quality threshold's a bit higher, up to about 80, 90, 100,000 pounds per quality. I'll stop there.
Ace, thank you, Paul. That's really interesting. I see in the Q&A that we also have a comment from one of the other attendees on the same question. That's from Leo Ho. And just for the benefit of the recording, because I don't think that's going to be captured in it, I just want to share that Leo says NICE is changing the threshold from 20 to 30,000 pounds to 25 to 35,000 pounds. So if a medicine falls in that range, the NHS in England has to make that medicine available in England for use within 3 months.
Yeah.
So that's very interesting.
Yeah, just happening. Yeah.
Folks, do continue to raise your hand or put on your camera or drop your question in wherever you like. There's a couple more that I wanted to deal with. B's next question. She's recognizing that economic evaluations can make for very headline grabbing conclusions of for every pound spent, it can yield whatever saving. And that can be very attractive to decision makers politically as well as quantitatively. But that can also mean that nuance is lost and interventions that might be taken forward that have a little more complexity to them might be overshadowed. What's your stance on that? And how would you recommend such conclusions are presented to still have impact and reduce the risk of misinterpretation?
Yeah, that's quite a common thing you see happening, and that you can undertake evaluations to present your program in a good light by doing all sorts of making all sorts of potential, which are assumptions, and then if they're not evidence based, then it becomes guesswork. So you'd want to make sure something is evidence based, and even if it is evidence based, in terms of you've done a study which has got some information, let's say it does get people back to work, and you have got a proper comparator, relative to comparator group, where there was a different program running or the standard program running. You've delivered this program, this like 10-20% improvement in people's employment, which is a big effect actually. You would want to, this is where it becomes really, really important to get the science right. So peer-reviewed publications, we would want to see those the messages from peer-reviewed publications usually have more credibility because other experts have reviewed those assumptions and they've stood up to scrutiny, and they've queried, let's say, some of the headline findings that, okay, you've said that a £1 spend gives you £8 return to society in terms of, and seven of those pounds come from employment. You'd want to scrutinise that was attributable to the programme. That's quite a hard test to do. So, and it's you'll want to make sure that isn't, an assumption. But yeah, that is one way to get a high. So there's another method called social return on investment, which so a lot of economic evaluations, if they've included some of those are just cost and cost saving studies, I have to say, and as Martin's point was made, these often aren't cashable savings, so there's savings in the system, which is a good thing if there are waiting lists and waiting times in the system. Yeah, and some serious problems in waiting times and waiting lists at the moment. So those are valuable to patients in terms of health gain. So we'd be doing it for that reason rather than to pull money out of the budget and close wards and reduce staffing. But yeah, we really have to be careful that we're not over extrapolating the gain, and you just have to be careful and scrutinise the figures. If they look too good to be true, the old adage, if they look too good to be true, they often are. When you get down to the evidence base behind them.
That's great. Thank you, Paul. There's a couple of follow-up questions that have come in off the back of B's one. So Martin Wiley asks, where do ethical considerations play into the evaluation when having to ration resources?
Right. So one of the reasons why cost-benefit analysis isn't used is that ethical dimension, because it's based on people's willingness and ability to pay for things. So it kind of sidesteps that if you do use cost-utility analysis and the QALY. However, the QALY has been subject to the claim of ageism, which there is more than a grain of truth in that, it has to be said. When you're comparing potential QALY gain of a program, the more time people have to live, and if that program improves quality of life, the more QALYs there are to gain, because your quality of life, if it's maintained, is maintained over a longer time period. And then, of course, you're subject to all sorts of age-related disease anyway. But everything else being equal, you are more likely to gain more QALYs the younger you are than if an intervention is left later in time. And I don't know if NICE really had done much about that, has to be said. There was lots of debate, 10, 20 years ago around age-adjusted QALYs, and there's been some work done on that and given some extra weighting to compensate people who are at older age to equalise the playing field. That some of that's been done. It's not really taken off. So again, NICE is not recommended. Neither is SMC, Scottish Medicines Consortium, that any age adjustment is done. The thing that maybe argument against actually that being a major issue is quite often the comparisons are within that health space. So the incremental cost effectiveness approach, compared with usual care or current treatment, does this new treatment improve things, right? So so if you can meet that hurdle, that kind of because usual care or current care again is being applied to the same age group, it doesn't really directly affect it. It's only when you're making those broader comparisons across different disease categories and constructing, say, potentially a league table of cost per QALY estimates, that the ones higher up, there might be an age effect at play there or not. But that, I think age is one of them. I'm not sure about income, not sure about deprivation. One of the big issues is lots of studies are not particularly representative enough. And so, it's difficult to tell. There is now more weight put on, and this is quite a recent development, around something called distributional cost effectiveness, and we're doing some of that work ourselves now. So rather than just taking the average cost effectiveness estimate, for program A, and this is the average. So the average, this is what you expect again. You can slice it up such that you can see, well, what does it look like for people from different parts of the country or different SIMDs? If you've got the data to do that, you can potentially, but then you've got to be careful with that. What happens if, the QALY gain is very different in different groups? When you start to look at this, would decisions be made on that basis? Probably unethical to go down that route. So you tend to this is the average based on the population we have. There's some statistical uncertainty around the average because people's ability or people's kind of genetic makeup, physiology, where they live, all impacts on the improvement. And we take all that together, and this is the average effect. Are you going to say yes or no to this new way of delivering programs to people? And we've got to be careful about subgroup analysis, and if it tells you something that's at odds with another criterion, I don't quite, it's up to, I guess, the decision maker what to do with that information. They could be trading off efficiency against equity. The two could go hand in hand. Maybe the gain is highest amongst the people who are the most in need. That would be really quite important finding. Yeah. Okay, thank you for that. That's a good question.
Thank you, Paul. There's another question in. This is from John Mulhern, and he's asking, do you think that social work is undervalued in terms of economic evaluation within integrated health and social care systems?
It's not one of my areas, I have to say, but there could be an argument to be made that it is, because I do suspect a lot of the research resource is directed towards health, the healthcare system, rather than the social care system. Not to say there isn't any evaluations being done there, but there's just and things are better than they were. I don't know if there are specific challenges there, but I think there probably isn't a level playing field, that there's not enough research resource directed to that. There is, it's certainly in England, there's a School of Social Care Research. So there's maybe England are ahead of Scotland in terms of ring fencing resource to kind of look at that and develop more evidence for social work, social care, and how to improve, improve the current allocation. But yeah, it's not something I know too much about here.
Thanks, Paul. It brings to mind my own question, which is, I'm coming away from this session educated, but also highly intimidated as far as how extensive the prerequisites are in order to conduct economic evaluation. I don't know, but there's no end to the things I don't know, so to take what I'm asking as incomplete information, but I don't know if we have the equivalent of a cost book. I don't know if we know how much does it cost for a social worker to take on another case, or how much is saved if that case can be closed. I don't know, is there EQ5D data where the issue being examined is a social determinant of health rather than a health condition itself? If the local authority sector wants to start moving towards economic evaluation, where do we start?
Good question. So I guess you'd be looking at, if you can, what are the programs or interventions that the public are receiving, the service users are receiving there, what are the problems that people are referred for. So that's giving you a sense of what, and you could look at that in terms of just a volume question, to begin with. Where are the pressure points in the system? You may have done a survey as well of, a survey of service users. Where are people most unhappy in terms of their service use, in terms of waiting times, waiting lists? Is there a mismatch between supply and demand? So that allows you to kind of home in and set up the research question to begin with. So that the challenge is often setting up the research question and once you've set up the research question, is it researchable? Is the next thing. I don't know if this was covered in the evaluation session. Some things are, if there's a system change, you think, oh, that's a system issue, which is bigger than doing a piece of research. So let's again go down a more micro level. And I think you start from the bottom up, and it's about what the service users receive. What do they think about the services they receive? So that could be quite standard kind of, dare I say, satisfaction questions. But it's a start if you don't already have that information. And then you're looking at what comes back from that. You may want to be digging deeper if quite often the challenge with service satisfaction questions that the people who respond are the people who are maybe least satisfied, or the other way around, that you get a extreme opinion, and it's selective opinion. And then it may be, some of this is, a lot of it's maybe to do with workforce and training of workforce as well, or adding to the workforce in particular ways, and where to add. And again, that might be around waiting times, waiting lists, levels of, people are less satisfied in certain areas because of these factors. And then looking to see, again, I've made the point that qualities are kind of there in the healthcare system, but you can, what would happen if you expanded the social work team by one, if the question is one extra whole-time equivalent? What does that do in those indicators in terms of waiting times, waiting lists? What does it do for service user satisfaction? And to get under the bonnet even more, what are people's capabilities? So the capability measure, as I talked about briefly, as a a social care equivalent of, could be seen as a social care equivalent of the EQ5D in health. So it just gives you the summary score of whether things have or haven't improved over the piece, and it's weighted according to what people have said in previous surveys that matters to them. So you can start to kind of track improvement, and then you've got the cost, the direct cost of it. So what does it cost to achieve this improvement? Well, it's an extra whole-time equivalent who costs X amount. The knock-on effects of helping people in terms of reducing waiting time, waiting lists, improving service satisfaction. You can track that and weigh up that extra whole-time equivalent. Any impacts on other parts of the system in terms of health and social care use. Put those two elements of cost together and weigh that up against the improvement you're seeing in those outcomes, and then you've got yourself a cost consequence analysis there, and cost, there's some type of economic evaluation there. You can put the nuts and bolts together, I think, in social care and other parts of it. It doesn't need to be EQ5D all the time.
Brilliant, Paul, thank you. Let's do it.
You're on.
Okay, we're just up to time now, and I don't see other hands raised. So thank you so much, Paul, for introducing us to this topic. It's definitely going to be something that I'm continuing exploring. I hope other people are as well. I dropped a feedback link into the chat, so please do share your thoughts on the session. We would like to hear. This session recording will be shared hopefully by the end of the day if I don't have too many emails. And thank you so much for coming, everyone. Maybe we'll see you again at the next seminar, date TBC. I'll release you back to your afternoon.
Thanks,
Bye, folks.
Bye.